sharing experiences, really important. Learning from each other, hearing from our expert speakers.
I want everyone to really take control of their health, because it's your body and your life, and if you're not in control of it, no one else will be.
Turns out that almost all pacemakers are completely fine to go through an MRI scan.
Both septal ablation and surgical treatment show good results. It's safe, comparable.
HRT for many women is a lifesaver.
However, and it was a real shock, they told me I did need a transplant.
It's funny being a carer. You know, sometimes people don't take their medicines properly and you get cross at them. Why are you not taking your medicines?
I would say the next big stage in the development of this story was our understanding that this is, in many people, a genetic condition. So it's a heritable and transmissible disease.
So some of the pros of genetic testing are that we can find a causative gene change in some people.
Morning, everyone. Actually, that's pretty good. That's pretty good. Normally it's morning. How many of you came last year? Okay, so that's good. So there's a lot of new people. The purpose of these sessions is to be interactive and to answer questions. So I'm not going to spend a huge amount of time on the presentation. Please ask questions. We've got this complicated card thing, but really, if you don't want to, I'm not supposed to say this, but just put your hand up and I'll repeat the question. Okay. Sorry. It's a rotten name, that, isn't it? Hypertrophic cardiomyopathy. Whenever I see people in the clinic, I spend a little bit of time at the beginning just trying to explain what that means. Because, you know, you're aware that medics are like priests. We invent a language to put a barrier between you and us. All that means is thickened, and all that means is heart muscle problem. So it's a very, very descriptive term. And for 30 years, 40 years, 50 years, we've defined this condition simply by measuring how thick the heart muscle is. And if the heart muscle is thick, and that's not explained by other common conditions, such as high blood pressure or aortic valve disease, we call it hypertrophic cardiomyopathy. That noise is really getting on my nerves. As I say, we've been talking about this condition for a very, very long time. We can go back to William Harvey. René Laennec invented the stethoscope. Makes me really cross, but the first person who really described outflow tract obstruction was a Frenchman, but there we are. Donald Tier was a society pathologist, I would put it. He was always being driven around London in a Rolls Royce to do postmortems. He did Jimi Hendrix postmortem. He did a number of other famous postmortems. The reason he was driven around London in a Rolls Royce because he liked champagne rather too much. But he was the first one who described in the modern era the disease, the thickened muscle and what we see under the microscope with disordered arrangements of muscle cells, abnormalities of the mitral valve. And we've been reinventing it since then, since the 1950s. I would say the next big stage in the development of this story was our understanding that this is, in many people, a genetic condition. So it's a heritable and transmissible disease. And this is my erstwhile boss, Bill McKenna, in London, working with the Seidmans in Boston, studied this large French-Canadian family. Now, in this era, you needed families this big to discover new genes. But using this large French-Canadian family, where there was a lot of sudden deaths, etc., they identified the first gene for the condition. And I just showed this picture. This gene affected one of these key proteins that cause the heart to contract, a protein called beta-myosin heavy chain, this one. So there was a lot of excitement about that. We've opened up the cause of this disease. But then it became apparent that the majority of people with the condition didn't have variants in that gene. And since then, it's basically been a protein a year. Pretty much all of the protein components of this motor within our cells, what we call the sarcomere, have been implicated in disease. And if you put all these together, even that doesn't account for the majority of disease. It accounts for maybe about 40% of disease. Oops, excuse me. Come on. That's weird. So 40%. What does everybody else have? Well, some people have weird and wonderful stuff, the genuine rare conditions. And I've listed some of them here. Some of them are very age-specific. So some of these rare causes affect largely children. I mentioned a condition called amyloidosis in the large room. That tends to affect older people. But you know, some of these things are genuinely very rare. Some of them are rare because we don't look for them systematically. I would say probably this is about right. 5 to 10% of people will have one of these rare causes. And then you've got this big slice of unknown, and that's a mixture of stuff. That's a mixture of combinations of things like being a bit overweight, sleep apnea, hypertension, and probably still a few little genes. What I've put here are some papers that have been published in the past 5 years identifying genes which account for maybe 1 in 100 people with the disease. This is to make this point. There is an interaction between common conditions and rare. So if you carry a genetic variant, then if you are a bit overweight, if you have got high blood pressure, if you do have sleep apnea, if you do have diabetes, that will probably make it worse. A few questions. How common is it? It sounds less and less now, I think, but people often, when they're given this diagnosis, they feel very alone because this feels a bit rare. You know, am I the only person in the world with this thing? This goes back to the guy who first used the term cardiomyopathy, Wallace Brigden. And these two statements from 1957 are less true than they used to be, but they still apply. The true incidence of these diseases is unknown, but it's probably higher than is generally supposed. If we don't look for things, we don't diagnose them. And this one, certainly when I was training, was true. There was this reluctance to use the label. You know, well, if I tell them they've got hypertrophic cardiomyopathy, that might worry them. That was the kind of medicine that was being practiced when I was a wee lad. Well, yes, they might need to be worried, but we can do something about that. I think this is less of a problem now. Now, how common is it? Many of you will probably be familiar with this number 1 in 500. And that's sort of true. Yeah, if I were to take an echo machine out into Liverpool Street Station next door and scan everybody walking past, I would probably find that 1 in 500 of them had a thickened heart muscle. But probably the majority of those people will never have a problem. The issue is how many go on to have a problem. And this is a study we did a number of years ago looking at electronic health records in the UK. And there it was more like sort of 3 or 4 per 10,000 of the population have disease. And these are people who are presenting with a problem. So it's the other end of the scale. So the truth probably lies between those two numbers. The other thing, if you just look at, in fact, all of the cardiomyopathies, this is over an age range. Most people being diagnosed not in their teens, not as young people, but in their 40s, 50s, and 60s. And the other thing is that during that 8-year period, the frequency of the diagnosis increased by almost 60%. Not because HoCM suddenly became more common, but my point about the fact that people are more relaxed about using the terminology when they make the diagnosis. How is it diagnosed? Well, it makes me so sad. I'm a dinosaur. Not only do I carry a stethoscope, I actually use it. And my young colleagues carry a stethoscope like a staff of office. Can they use it? No. But does that matter in the modern era? I don't know. But certainly hypertrophic cardiomyopathy, particularly the obstructive form, is a godsend for examination. But of course, we use other tools to make the diagnosis. So we use the electrocardiogram, which doesn't tell you have HCM, but it's a very sensitive test. It picks up abnormalities early in the development of the disease. So it's particularly useful in screening families, for example. But of course, the cornerstone is imaging the heart itself. And ultrasound, echocardiography remains the major way of doing that. what you see here is, this is the left ventricle, this is the right ventricle, that's the wall between the two chambers, and that should be about the same thickness as the back wall here. So that's a very thickened heart muscle. And this is still the way in which we pick this up in the overwhelming majority of people. Echo can be used for a number of things, not only how thick the heart muscle is, how well it's contracting, some fancy techniques we can use to look at how bits of the heart are contracting relative to others. Of course, the sexy way of imaging the heart has been for the past 10, 20 years, magnetic resonance scanning. Anybody had it? Yeah. Keep your hand up if you enjoyed the experience. Really? It's not a nice test, is it? Particularly if you're a bit claustrophobic. It shows us the same kind of stuff as echocardiography, so it shows us thickening, but the thing it brings to the table is an ability to look inside the muscle, if you like. So it can show us scarring, it can show us infiltration, in this case by amyloid protein. So it's become part of the standard workup, at least, and this is rarely I say this, at least in the UK, because we have a culture of MRI, but globally, MRI is still a rationed test, and in some parts of the world it doesn't exist. So what I said in the other room was that sometimes I think cardiologists still think, oh, it's just imaging, that's all I need to do to make a diagnosis. But it's not just that. Because in a way, hypertrophic cardiomyopathy is not a diagnosis, it's a description. It doesn't tell you what the underlying cause is. And to do that, you've got to integrate the family history. Yes, look at the imaging. Are there other clues? But you may need to do genetic testing, you may need to do particular laboratory markers, you may even sometimes need to do a biopsy of the heart. But making a diagnosis is more than just describing the thickness of the muscle. Okay, treatment, I sort of touched on this, but my approach in the clinic to this disease is to sort of try to sort of put things in boxes. When I'm talking about, what are the risks for you with somebody with cardiomyopathy? There's basically three things that we worry about. This is the one that obviously grabs the headlines, the risk of dying suddenly. The second is the risk of developing progressive heart failure. And the third, this is atrial fibrillation, irregular rhythm in the top chambers of the heart, which might cause a stroke. Fortunately, the majority of people with this disease are not at risk of those things, but our job is to identify those individuals who are, because we can do a lot, certainly about that and certainly about that. Of course, the management, the treatment of the condition is more than just pills and defibrillators, however. And as many of you will know far better than I do, it's the symptoms, but it's how those symptoms impact on your ability to function. You've got young kids. You know, as a father or mother, that if you go out and play, kick the ball around in the garden for an hour or so, the next day you are going to be flat. No energy. It has an influence on your own personal psychology and on the psychology of those around you. Employment. I won't ask for you to raise your hands for this, but how many of you have told your employer that you have cardiomyopathy? Please don't put your hand up. Maybe that's the answer. But a lot of people don't, because of course, although there shouldn't be, there is discrimination within the workplace if you tell someone you've got a heart problem. And of course, the perennial problem of insurance. How do I get insurance? Travel insurance, life insurance, a mortgage, etc. So managing this condition is more than just pills and defibrillators. But, when I have someone in front of me in the clinic, we talk about how it's inherited and the impacts that has, what symptoms do you have, and what are your risks of complications. We talked about the sudden death issue. Now, one of the things I generally say is, look, for the majority of people with this condition, the risk of sudden death is very low. This is the Google moment for hypertrophic cardiomyopathy. I talked about the Google moment for dilated cardiomyopathy, but for HCM, is that, oh my God, I've read about all these young footballers dropping dead. They've all got hypertrophic cardiomyopathy. That's going to happen to me. For the overwhelming majority of people, that doesn't happen. Oh my God. Not only do we, now we're getting an earthquake. Oh my God. But I'm going to carry on. the overall excess risk is small. There is an excess risk. Actually, the excess risk for women is greater because women's overall risk of bad things happening, particularly when you're younger, are less than men. But HCM substantially adds to that risk if you're a woman. And also there's a curious thing. We think that probably by the time you get to 60 as a man, on average, and there are always exceptions to this, men's survival curves approximate to that of the background population, but women remain at higher risk. For the sudden death issue, we do a lot to try and identify those who are at risk. Of course, we do that because we have something to protect people, the defibrillator. These are the guys that first invented that. Can you imagine being the first person to receive this? Open heart operation, the defibrillator was about this big, moved around on a trolley. But that's how advancing in medicine progresses. Since then, we've gone from something this big to something about that big, which is now implantable under local anesthetic, usually, connected to a couple of wires inside the heart. Long term with these devices, the problems often relate to the wires inside the heart, as you can see here on this X-ray. So new technical developments, developing devices which the box is still under the skin but out here, and the wire is underneath the skin and nothing inside the heart, which reduces the long-term risk of device-related complications. How do we identify those individuals who are at risk? We do risk scores, just in the same way as an actuary will define your risk of bad stuff happening. We're trying to do the same for conditions, diseases, and that's what I say in the clinic. That's the closest I get to a crystal ball. So based on 8,000 people with the condition, we can estimate the risk from your age, how thick the heart muscle is, how big the top chamber is, whether you've got obstruction, blah, 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 blah. And we can use that to generate an estimate for your risk. And then we have a conversation. Because this tool that we've developed generates recommendations, but forgive me if some of you have heard me say this before, who defines what acceptable risk is? What is an acceptable risk? I mean, I can tell you this came from the 2014 HCM guidelines. I chaired them actually. But I know where this recommendation comes from. It was 20 people sitting around a table saying, well, I think 5% at 5 years is, well, no, that sounds a bit low. What about 8%? No, maybe 10%. That's how it was determined. That's what we say when we say consensus. And it came out at roughly about a 1% per year risk. But the reason to generate a number is you can have a conversation, because of course we all have our own individual acceptance of risk, and that changes throughout our life. So the risk you accept when you're 16 is not the same as you accept when you're 35 and you've got 2 young children, or when you're 83. It's different. This is from the latest guidelines. It's essentially the same thing, calculate a risk. And the one thing I would say is that if you have no risk factors whatsoever, and you are at very low risk, it's hard, at least in the way I think, to justify putting in a defibrillator. But this is the conversation we have in the clinic. Oh, shared decision making. This has become a new mantra. What most doctors mean by that is, well, of course I do shared decision making. I talk to my patients. That's not shared decision making. It's part of shared decision making, but shared decision making is a deliberate process of sharing information and providing people with the tools that they need to participate in the decisions about their care. Very quickly, I mentioned this. This is for hypertrophic cardiomyopathy. This is the cause of symptoms in many, if not the majority of people with symptoms. It's this problem here. Here's the left ventricle. Here's that valve. Do you see it sort of doing that, coming forwards with each heartbeat? And it's causing obstruction to the outflow here. There it is in diagrammatic form. And so the way we treat that is to give drugs which reduce the force of contraction of the heart. So we give beta blockers. How many on beta blockers? Keep your hand up if they work. Yeah, that's really interesting. So we had, I'm not sure if they help or not. That was very interesting. Verapamil, anybody on verapamil? Yeah, that's all. We sort of got out of the habit of prescribing that. And disopyramide? Yeah, when you can get it, exactly, that's the problem. That's the problem. So this is actually an antiarrhythmic drug, which almost as a side effect reduces the force of contraction, but actually there's no market for it now. So we keep getting these shortages, and I think it's going to disappear completely. It's not a great drug, mind you, because if you go onto this, you can't see pee or poop, basically. It does lots of nasty things to you. Sometimes we use diuretics, water tablets. If that doesn't work, the traditional way of dealing with this is to do an operation where you reduce the thickness of the muscle. Oops, it's always embarrassing when you come out on a stretcher after a talk. So this is a deceptive operation. So what happens is you go onto bypass, the surgeon actually not this lurid opening up of the heart, that's not what happens. What the surgeon does is he opens up this big blood vessel, the aorta, and he looks down through the valve and removes the muscle from above. That's a really hard thing to do. But that's what they do. This is what I call the Michelangelo complex. Some surgeons say, I'm going to reshape this ventricle. That's not a good thing to do either. There are very few surgeons now, or indeed ever, who've had a lot of experience with that operation. So alternatives have been sought. This is the other major one in town, which is where we put a catheter inside the main artery running down the front of the heart, the LAD, little balloon, and squirt alcohol into the muscle. So we're trying to, if you like, chemically shrink the muscle, chemically mimic what the surgeon does. And this has got a number of advantages, fewer complications in relation to surgery. Honestly, I think it's less effective than surgery, but that's my own personal view. So we've had a lot of things, but it's not the same treatment for everybody because you have to tailor the therapy. Because it depends on many things. There's, of course, preference, but it's also whether you have other disease, whether you've got coronary disease, whether you've got something else wrong with your mitral valve. So there is no single way of managing this. I've talked about the new therapy now, Mavacamten, which is a drug which reduces this binding between the proteins inside the heart muscle, and the randomized trial showing in about 30 to 40% of people with obstruction, who already received standard medication but are still symptomatic, you can reduce the obstruction, reduce the biomarkers, etc., etc. Okay, very quickly, give us some time for questions. The stroke risk, this sometimes gets forgotten. So there's a big focus on defibrillators, big focus on obstruction, but we really need to focus on stroke risk as well. And basically what this is showing you is the risk of having a stroke against the size of that top chamber of the atrium. The bigger the atrium gets, the more likely it is you're going to go into this irregular rhythm atrial fibrillation. If you go into atrial fibrillation, you're at high risk of stroke. So we actually often give blood thinners to people who've not yet had atrial fibrillation, but who have a really big atrium. We don't have, and we never will have, a randomized trial in that, but at least for observational data, you can substantially reduce the risk of stroke by giving blood thinners. Previously warfarin, now drugs which are called DOACs. The thing which we're not good at is this one, which is the risk of progression to heart failure. And we don't do anything knowingly that reduces the likelihood of that. So that, for me, is now the big frontier in hypertrophic cardiomyopathy. Sudden death, fortunately, is a really rare event now because of everything that we do. Stroke, I think we can prevent in most people, but how do we prevent disease progression? And this takes, it's not 5 years or 10 years, it can be 20 years or 30 years. At the moment, we do the same thing as we do in other types of cardiomyopathy, so we give beta blockers, we give diuretics, we give ACE inhibitors, and blah, 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 but we have no real evidence that they prevent disease progression. And many trials, drugs not really working. The hope is that the new generation of drugs coming through and gene therapy. Okay, I'm being told I've got to shut up at 5 minutes. This is an old slide, but it's basically just to show you that within hypertrophic cardiomyopathy, people are thinking about many ways of improving outcomes, whether it be surgical or drugs or gene-based therapies. This is a really, really buzzy space at the moment. Okay. So, time for Q&A. Okay, folks, over to you.
So I have to press anything? Oh, hi, I'm Stephanie, and I was supposed to be here at the beginning, but I wasn't. I'm sorry, but I'm here now. So we've come to the end of Perry's talk, and we've all learned a lot about hypertrophic cardiomyopathy. Does anybody have any questions? Now, the way we're doing it this year is that you're writing it down on a piece of paper. So if you've written down a question on a piece of paper, if you can hold it up, and I shall collect them. Thank you very much. And if anyone's got a burning question, put your hand up, and Perry can answer that whilst I'm collecting these pieces of paper.
So
Anyone got a burning question?
Yeah.
Yeah, at the back there. Here you go, you can have this. Here you go. Sorry.
Hi, I've got HoCM, and I was in hospital last week, UCLH, and they were totally flummoxed by me.
Oh.
The whole hospital was asked what's wrong with this lady, because I had a really high lactate and I nearly died. And then I just said, I'm going to a conference next week. That was Professor Crosby. I told that, he was laughing. I said, I'm actually going to ask Professor Elliott this question. Is there a link between high lactate, I had lactate of 10, and HoCM? Yeah, I was really sick and they couldn't work out why. But then obviously they made me better because I'm here.
Okay. Listen, that's a really detailed question, but in short, there isn't, just because you have HoCM, so lactate is a substance produced from muscle and other tissues when you're producing too much acid in a way, and it can happen. It happens when we exercise too much, that's why you get pains in your muscles. It can happen when you're really sick and you've got septicemia. I presume there was no evidence for sepsis. It can also happen with some metabolic conditions. So has the cause of your HoCM been determined? Do you know do you have a gene?
I'm VUS.
In?
Variety of unknown significance.
Yeah,
I don't know what, I can't remember now.
Which.
It's like, I was the 30th person in the world to have that type of gene that I've got.
So, you know what I'm talking about, rare conditions? Here we are as a lady with a rare condition.
Thank you very much.
So basically so the thing that goes through my head is a group of conditions called mitochondrial diseases, which are, in all of our cells, we have these little sort of sausage-shaped structures which produce energy. They've got a little bit of DNA inside them, and if that goes wrong, it can give rise to a whole variety of different things, including cardiomyopathy. And it can also result in high lactate. So you can go and tell Professor Crosby that I spoke to Professor Elliott, and he said, it was mitochondrial disease. But perhaps we should talk again a bit later on. So the devil's in the detail.
Thank you very much. We now have a question on Mavacamten. Mavacamten, sorry. It's been a while. And its benefit for people who have had a myectomy. Mm-hmm. So I suppose, do they still have any obstruction? Can it be treated?
Yeah, so the drug, this is that myosin inhibitor, which reduces the force of contraction, has been trialled in the Explorer trial in people with obstruction. So the question is it useful if you've had a myectomy? Well, it's useful if you've had a myectomy which didn't get rid of the obstruction. So if you've still got residual obstruction, or if you had an alcohol ablation and you still have residual obstruction, then Mavacamten could be used. If that answers the question.
Yes,
yeah.
Thank you. In your slides...
Is that a follow-on from that? Yeah.
Carry on.
Do you want to speak into that?
Yeah, second question. It seems that genetic diagnosis is becoming more important to determine both the cause and the potential treatments, particularly with the new drugs. If the gene's not been identified in previous investigations, how often should you advocate to have it looked at again?
Yeah, it's a really great question. So most of the genetic forms of this disease occur as a result of a variant, a mutation in one of 8 genes. So if you don't have a variant in one of those 8 genes, then it becomes progressively less likely you're going to discover anything. However, as I showed on my early slide, we do keep finding these really rare genes. So often the clue comes from a family. So if it's really clear that something is running in a family, it just means we haven't found the gene yet. If it's you're the only person within the family with the condition and you've got a bit of high blood pressure and that sort of thing, then either it's a non-genetic form of the disease, or another form of inheritance is what we call polygenic. So we all have about 24,000, 25,000 genes, and we have lots of spelling mistakes in those genes, which usually don't cause any problem. But if you accumulate not one variant, but 50 variants or 100 variants in a number of key genes, then you may become more likely to develop diabetes, or you may become more likely to develop hypertension, high blood pressure, and probably the same is true for thickening of the muscle. So it may be an accumulated number of small hits which by themselves don't cause the disease, but increase your chance of developing cardiomyopathy. And that's leading to a whole industry built around what's called polygenic risk scores for estimating your population risk for developing any particular condition.
Right. Thank you. Just a question about your slides, Barry. One of your slides showed that women are diagnosed less with hypertrophic cardiomyopathy. Is that because of the, it truly is genetically less in a woman, but it's 50-50, isn't it? Pass on. Or is it because women are less frequently diagnosed? Or what is the reason?
Is it a plot by the patriarchy, do you mean?
Yeah, maybe. No, but why are less women?
Yeah, no, it's a really good question. I mean, if you start from the premise that in a significant number of people this is a genetic disease, then there should be no sex difference. It should be the same number of men, same number of women for this particular type of genetics. But in virtually every series of people with HCM, you get a male predominance. And actually that's become greater over time. So it used to be about sort of 55, 60% men. We're up in some series up to 75, 80%. Number of possible explanations for that. Men and women present differently with symptoms. We know this from other cardiac conditions. The paradigm for coronary disease is quite a male one. You present with central chest pain going down your arm, and blah, blah, blah. Women with coronary disease often don't present in that way. They might present with breathlessness, for example. So it may be the way in which people present. Mm-hmm. It may be because we're using the wrong criterion to diagnose the disease in women. So, we have I showed one of my early slides was this magical number of 1.5 centimeters. More than that, you say, is HCM. But the hypertrophic response in women might be less. So actually in women, maybe we should be using a lower criterion. And there's some evidence of that from a big, I think, a study called the UK Biobank, where actually, I think, we should probably be using a different criterion for women.
Yeah.
It may be that, the answer I just gave to you, that some people have a thickened heart because they have high blood pressure, they're overweight, and they've got sleep apnea. Men tend to be more overweight. Yeah, sorry chaps, but they tend to be more overweight, have more sleep apnea and so on. So that may be skewing it towards male differences, but there's definitely a difference, yeah.
Oh, interesting. Thank you. A question now about longitudinal strain.
Oh my God, yes, right.
If you can briefly answer this, what significance does this mean when you see what the longitudinal strain is, long words, in relation to heart function in hypertrophic cardiomyopathy?
Who asked that question?
It's an interesting question because, we get all this. We get a letter from our doctors, don't we? Saying you've got this, that and the other. You've got longitudinal strain. You look it up and it says you're going to die in the next day. All these kinds of things. Look, it doesn't mean anything like that.
So this is I whizzed across this slide. So echo, ultrasound, shows this heart movement, how thick the heart muscle is. But you can see how it moves, how it deforms. So strain is that. So the common measurement we use for estimating pump function is this thing called the ejection fraction. You've probably all seen it in your letters, which is basically the difference between that and that. So it's what proportion of the heart's content is ejected with each heartbeat, and that should be more than 50, 55%. It's a very crude measure of how the heart beats. Instead, what we can also do is to look at the muscle and see how well it's deforming. And we can do that way, that way, that way in different planes. So strain, that's all it means. It's how well is the heart deforming. It's another way of measuring function.
significant the larger the constraint you do?
It's nearly always reduced in people who've got definite HCM, nearly always. So it's like all these things. There's no single number which tells you how bad something is, what's going to happen. If the ejection fraction is really low, if there's a lot of scar, if the global longitudinal strain is reduced, it's all consistent with the fact that the heart muscle is quite significantly involved. It's just one of those numbers you put into the mix. Does that make sense?
Yep, very good. Thank you very much. That's
That was a good question, wasn't it?
yeah, it was a good question.
Yeah.
How do you determine whether medication is contributing to chest pain rather than a HoCM condition?
Ooh.
You know, if a patient with cardiomyopathy goes into the hospital, God help you. But, you know, sometimes they say, oh, you've got cardiomyopathy, that's why you've got chest pain. But what if you're having a heart attack? How can they tell?
Oh, yeah, sure. Yeah, so again, doctors are quite... So you walk in and say, I've got hypertrophic cardiomyopathy, I've got chest pain. Yeah, well, that's probably because you're HCM. Yeah, but I've never had chest pain before.
Yeah.
Yeah, but you've got HCM. Yeah, but I could be having a heart attack.
Yeah.
So that's one scenario where people just sort of attribute symptoms to the wrong thing. The question about the effect of medication, I think that's a broader question because we stick you on pills. That's why the beta blocker response was really interesting. We've been using beta blockers in hypertrophic cardiomyopathy since the 60s, 70s. It's almost become ritualistic. In fact, again, when I was training, HoCM equaled beta blocker. The problem is you put people on beta blockers and it often makes you feel less well. And yet we plow on, keep taking the tablets. I don't feel very well, doctor. Let's increase the dose. I feel even less well, doctor. Are you taking your tablets? There's a particular issue with beta blockers. That's a good one to start with. So here's a thick heart. Okay. When you exercise, you need to increase the amount of blood going around the body. And normally the heart does that by increasing the amount of blood, the ejection fraction, with each heartbeat. But in hypertrophic cardiomyopathy, the cavity is already quite small. There's not much room to increase the amount of blood with each heartbeat. So the only way in which you can increase the amount of blood going around the body is to increase your heart rate. So you get more beats. What happens when you have a beta blocker? You get less heartbeats. So actually, if you really want to reduce someone's exercise performance by about 10 to 20%, you put them on a beta blocker. Now, for some people, the response to beta blockers is very heterogeneous. Some people just suck them up as if they're not taking anything. Other people are exquisitely sensitive. But I think that what we're going to find, driven by drugs like Mavacamten, is that perhaps we should be using less beta blockers or beta blockers at a lower dose. Basically, if they're not working, why are we giving them?
Thank you very much. I've got a question about Mavacamten. Is that right?
Getting better.
So this one, somebody has HoCM and they're having joint surgery in 2 weeks. They take Disopyramide, but they've been told it's discontinued. How long before Mavacamten is going to be in? And there's another question about Mavacamten. I'll come to it.
Just call it Mava. It's much easier.
Mava, is that what you call it?
That's what I called it, yeah.
Okay, thank you. Well, this one says, can we recommend an alternative to Disopyramide?
Yeah.
So Mavacamten, when's it
So
coming?
Mavacamten is licensed in the UK. It's been licensed in the States for 2 years, I think. It's now licensed in the UK. It's variably licensed across Europe. The issue is that it's a difficult drug to administer. I've shown you how effective it can be, but one of the problems with Mavacamten is that it is a very potent reducer of heart function. And what you don't want to do is to overshoot and cause dangerous impairment of heart function. And so the protocol for administering this drug is very intensive. In that you have to have an echo every 4 weeks when you're starting the drug. And each time you change the dose, you've got to have another echo in 4 weeks. And then when you're on stable dose, you've got to have an echo every 3 months. The waiting time for echoes in many hospitals in the UK is about 6 months. Because it's a new drug, because of the concern about the safety of the drug, only particular centres are currently able to prescribe it. We are prescribing at our centre, so, Bart's big hospital, blah, 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 we see lots of people, but we can basically put 1 a week. And I think we've got about 4,000 people with hypertrophic cardiomyopathy on the books. And the reason for that is the echo system is completely overwhelmed with routine work. So we've had to create a separate clinic, separate clinical nurse specialist. We're using fellows to do echoes in their own time. That's how we're prescribing it. So it's not easy. But it will change. Because what will change is as people get experience with it, as we understand that it is in fact safe in most people, and I think the stringency of the monitoring will reduce. Yeah. But at the moment, that's why I think there were only 2 people who put their hand up in the main hall. You said they were receiving. Were you one of them? Yeah. Has it helped?
Oh, absolutely. Well, it'll take 6 weeks. And as you said.
Can I just give you the microphone, because we're all interested to hear this. Thank you very much.
This is divine retribution from Perry, by the way. So I've been taking it for 6 weeks. As you said, sometimes you can take anything up to a month or long. It kicked in after about 3 days for me. Mm. And the effects of, I try and be very careful, because game changer is not far off what I really think it is. Because I have less fatigue, I have more energy, I can walk faster, and the big test for me, I hadn't been swimming for about 3 weeks prior to that, and I was going down the swimming baths like 10 years ago. So when I had to stop after every length and let my heart slow down, none of that. Unbelievable. Yeah. So yes, I'm very fortunate to be on that drug. And I'm hoping that I'll be continuing for the rest of my life.
What dose are you on?
2.5.
Yeah, it's amazing, isn't it? So 2.5, we're not supposed to start at 2.5. I can tell you that now.
I said divine retribution.
Because the starting dose should be 5. That's how. Really? But actually, we've started at 2.5 because it allows us to get people started. Because there's another complication, so we have to measure a particular liver enzyme, which determines how high you can go with the dose. So rather than messing around waiting for the result of that to come back, we just start people on 2.5. And a lot of people are having the experience you've just described, even on that really ultra low dose. Some people are saying, this is incredible.
Fantastic.
Yeah.
Thank you very much for sharing that.
Can I just say, Libby, shall I get political? Okay.
Okay.
So look, there's a new drug available. We need you guys to pressurize for access. Okay, we can say, look, this is an amazing drug, but there is no funding for the infrastructure to support Mavacamten services. So, write to anybody you can think of.
What's the drug called?
Mavacamten, the trade name is Camzyos.
All right, good.
But we, the NHS is in a bit of a pickle at the moment. That might just been in a pickle ever since I've been a doctor, but it's a particular pickle at the moment. But we have this amazing drug. It doesn't work for everybody, but your experience is not unusual. Yeah. And it's outrageous that more people are not getting access to it.
And in the States, they are all taking it. Well, the people with HoCM.
States is interesting as well, because again, it's not as many people as you might think of receiving it, even in the States.
Okay, because when heart failure first came out with these drugs, what they're called, the ones were joint drugs for heart failure. Can't think what it is, but you had to go to get tested every 2 weeks and everything else. So as you said, screening will become more organised and things. I've got just going on to a question now here, Professor Elliott. You said we are not very good at the moment at preventing deterioration over time. What should young people do to help reduce deterioration?
Yes, I'm often asked that question. At the moment, I think, as I said earlier, there is an interaction between common conditions and HCM. So if you have high blood pressure, that's not a good thing to have. If you're diabetic, that's not a good thing to have. If you're overweight and you've got sleep apnea, that's not a good thing to have. It does interact with the underlying condition, whether it's genetic or not. So it's common sense health advice. Eat well, maintain a healthy
Exercise.
etc., etc. So there's nothing magic. There's nothing beyond that which, as far as we're aware, specifically modifies the disease itself.
At the moment.
But being healthy makes a difference.
Is there anything in the future, anything coming that could prevent the deterioration?
So there's a number of ideas. So there are drugs called SGLT2 inhibitors, dapagliflozin. Anybody on that?
Yeah.
Yeah, there we are. There's another one called empagliflozin. So this is a drug which was actually developed for treating diabetes. One of those serendipitous findings that it seemed to reduce heart failure events in people who had diabetes. So now we've got a number of trials using it in people with DCM effectively, or coronary disease. So it's being used sort of quite a lot in people with hypertrophic cardiomyopathy. There will be at least 1, maybe 2 trials of drugs from that class in HCM.
Yeah.
It's another one of it's a different pharmacological approach to managing the disease.
Okay, thanks. We've got about 5 minutes left because we started this a little bit late, so we're just going to continue for a little bit, 5 minutes.
Keep going.
Is that okay with you, Professor Elliott?
You know what I'm like, I'll keep going until the... Yeah.
I don't know what it's like. Yes. Can you please explain the link between sleep apnea and hypertrophic cardiomyopathy?
Sure. So there's two links there. One is if you have... So sleep apnea is... It's a condition which is usually diagnosed by partners, okay? So what it means is when you go to sleep, your airway closes up periodically during the night, such that you start to come out of deep sleep. You may not wake up, but you never really go into what we call REM sleep. So the next day you're completely knackered, you're very sleepy. It's associated with being overweight. It's loud snoring but loud snoring is very common. People don't get too alarmed. But if you've got loud snoring, the classical symptom, this is the history you get from the partner, is I lie there and usually he, will start really snoring loudly and then he stops breathing. How many times do you have to do that in the night? Or probably about 10. That's a sign of sleep apnea. It's managed, a number of ways of managing it, including nasal ventilation. The reason it's associated is because sleep apnea gives you bursts of high blood pressure, particularly during the night. So you may have a thick heart because you're actually hypertensive during the sleep hours, and that often then slips into the day, so you become hypertensive. Atrial fibrillation is more common in people, so that's one connection. There's another connection which is slightly more mysterious, and that if you have heart failure in its broadest sense, so if the heart is not, they're wrestling up, but if you have heart failure in its broadest sense, that often alters the way in which the blood senses carbon dioxide, oxygen. So one of the interesting things about heart failure is if you treat heart failure adequately, often sleep apnea disappears without any loss of weight or anything like that. So there is a physiological response of the sleep centers to having impaired heart function. That's the more complicated explanation for the association.
Thank you very much. I've got a question here from somebody who's been a patient of yours for 25 years.
Oh my gosh.
And had various things, had an ICD and things like that. But I think the question really is about, he had jaw pain one day and arm pain and went to hospital, and the troponin was 27,500, and he needed a stent in his LAD, which was 70% occluded.
Yep.
And he's just wondering, was that just bad luck that it wasn't picked up before, or?
Yeah. So 27,000 sporting, that means you've had a heart attack. Okay, so what we mean by a heart attack is that you've blocked an artery. There's no association between coronary disease and hypertrophic cardiomyopathy. So if you have HCM, you can get all the things that people without HCM have, including coronary disease.
Yeah, but I suppose all the tests that we have as patients is the only test that could have picked it up, an angiogram, I suppose it is.
Angiogram, CT angiogram, that sort of thing, because sometimes people will have a period of angina beforehand, but acute myocardial infarction often occurs in an artery with a relatively mild narrowing, a fatty plaque, as we call it, and it ruptures and causes a clot. So often there's no antecedent history of chest pain.
Can I just hand it to this person? Just a question.
Hello.
No, it's really interesting because Andy had his ICD done 5 days before, and then we had the heart attack a few days later. But
I just don't want to make it clear to everybody, I didn't put the ICD.
No, you didn't. And it was nothing to do with the ICD, and they said that. It was just one of those things. But the interesting thing was that I realized that for about 7 months before, he had really chronic snoring to the point that I was sleeping in another room a lot of the time. I even recorded it because it was so bad. It really was. Since he's had the stent put in, it stopped.
Is that interesting?
Yeah, and I just thought, and someone else said that the other day about her husband. Once he was stented, his snoring stopped. So I was just curious because... Yeah.
Was any of the medication changed?
The only thing they did back in January was the Dagiflow.
Added the Dagiflow.
Yeah, started in January.
So, look, I can make things up.
Thank you.
As I say, there's definitely a connection between. So, for example, I don't know if any of you have got what we call cardiac resynchronization therapy, pacemaker, which improves the contractility of the heart. In people with heart failure, when we put that sort of thing in, then sometimes people will come back and say, my sleep apnea has gone away because the heart function is better. I will be surprised if a coronary stent do that, but I wonder if the Dagiflow has done it.
Thank you. And I'm sure you've got more questions, but we've only got time really for one or two. It's nearly 11:40 and that's time that we're going to go for our break. But just a quick question here. Is it still okay to take bisoprolol and disopyramide together? It is, yeah. In fact, we often do that because sometimes disopyramide, if you go into an atrial arrhythmia and like atrial fibrillation, the heart's response to that may be more rapid without a beta blocker. So we often use them together. Okay, thank you. Well, we've probably got about 2 minutes. I've got a few questions here that haven't been answered, and we can put them into the main question and answer afterwards because it's time for us to have a break so that we'll be ready for our next talk. Is that okay? So we can go out. Well, the session is now over. Thank you very much, Professor Elliott.